disgusting. People dying because they are so desperate, chasing the dragon. Good evening, everyone. I'm Liz Hurley, WAFF 48 News Anchor. Thank you for joining us here at Bob Jones High School, live in the auditorium. Thank you at home for watching us on WAFF.com and on the WAFF 48 Facebook page. We'll be taking questions here in just a little while and also questions at home. So if you have those, please go ahead and get those ready. Tonight, our goal is to make you more informed. But first, I want to ask you a couple questions. Just a show of hands. How many of you are here tonight for a personal reason? How many of you are here tonight because of a professional reason? How many of you are here just because you want to know more about this opioid crisis and how it's impacting us on so many levels in our society? Everybody. Great. We are so glad you are here tonight. We have an esteemed panel here who's going to be answering a lot of questions for us. We're going to dive deep, have an in-depth discussion about the opioid crisis in our own backyards, in our schools, in our churches, in our workplace throughout North Alabama, and how that plays with the rest of the country. First, though, I'd be remiss if I didn't share some breaking news with you. Monday, federal agents raided a doctor's office just across the state border in Lewisburg, Tennessee. A doctor who had a practice here and a practice as well in Decatur, whose license lapsed, who went to practice solely, again, in Lewisburg, Tennessee. Law enforcement there tells us that it was raided on Monday. It was reopened on Tuesday. The doctor, my understanding, still practicing inside. Car tags coming from at least 4 states in the southeast region, all coming there for prescriptions. Today in Montgomery, during our 4 o'clock newscast, I shared with you a doctor and a nurse at a practice there who've been indicted. 2 of 11 within the same practice, allegedly operating a pill mill there. Also, in Washington, within the Beltline, the White House today had an opioid summit. It was held today. President Trump, along with his cabinet there in attendance, David Shulkin, Veterans Affairs, said, instead of reaching for opioids initially, we have to really have a different approach here. We have to not begin with pain management when it starts with opioids. We have to end there. But perhaps more poignantly, I heard an unbelievable and very special interview with Dr. Ben Carson, a neurologist who's also the head of HUD. He said, until it becomes easier to get treatment as it is to get the drugs, we're not going to win this opioid battle. Here tonight, immediately to my left, is the Senior Supervisory Resident Agent, Pat Stokes, with the FBI here in Huntsville. Dr. Sherry Squires, my friend, who is the director of the Huntsville Hospital Emergency Room, also the medical director over HEMC. Mr. John Howell, to her left, Chief Executive Officer from Huntsville Emergency Medical Services, HEMC to most of us. And to his left, we have Officer Teresa Taylor Duncan, street crimes investigator with Madison Police. To her left, Mr. Tyler Berryhill, Deputy Coroner for Madison County. And to his left, Mr. Telly Lanier, the Substance Abuse Specialist with Wellstone Behavioral Health Services. And then we have Ms. Karen Croson, a retired pharmacist. And let me see if I'm missing anybody. And then we have Agent Brett Hamilton with the DEA. There we go. Script complete now. Thanks again for joining us tonight. If I might ask you all first, tell us a little bit about your purview and this opioid crisis. What you do on a daily basis and what you see.
The FBI is a supervisor.
deal with patients suffering from opiate abuse issues, whether it's an overdose or death, and that's the really tough ones. In the film, they talk about telling people that their child parent, has died of an overdose. That's the toughest one. We also see people go through withdrawal. We see them when they are at low points. They have had car crashes, infections, or complications in the final stage, infections of all kinds. Admittedly, we don't see these patients when they are at their best. They're often very difficult. They have hit rock bottom.
John Howard had the distinct pleasure of hanging out at MC a lot the last few weeks covering this opioid crisis on a day-to-day basis. Your paramedics are hitting the streets, and those calls keep coming in. 1 or 2 a day, 1 or 2 a week. Sometimes, as I witnessed last week, 2 in one spot at the same time.
That's not uncommon. Last year, in our service area, we responded to 931 instances. So, 931 times last year, we went out on call for an opiate microdose. We see some of our patients multiple times. Sometimes we're seeing people 2 times, 3 times, even up to 6 times with the same problem. And we saw about 41 people who were called to die in the field last year, just in our community.
So you have a lot of repeat customers.
We do have repeat customers. And we typically know that when we start to see them repeat with us, that their chance of dying will more than double.
You told me you'll go out there once or twice. That 3rd time, they don't always make it to the emergency room.
Usually don't make it.
That's a tough pill to swallow, literally. Officer Taylor Duncan, tell me, on the streets of Madison, we've heard from Chief Jernigan recently about the pervasiveness of this opioid crisis. Many people would be in denial about that. It's not happening in my backyard, not happening at my child's school, not happening at church, not happening at work. What are you seeing in the city of Madison?
What we're seeing is a steady increase. In 2015, in the city of Madison, we had 1 overdose, between 2016 and 2017, those numbers rose from 32 survived overdoses and 11 deaths. We saw chasing the dragon, and myself and my coworkers every day. We chase the dragon, we chase it on the other side. We are actively involved in some community education. We have ongoing investigations that we was not done. Our cases aren't being given to us for the investigators that are on the ground. We have a car break case, we help them enforce that case. We go out and we actually find our
I do want to talk to you about that because, again, Chief Jernigan talked about that in his opening remarks. Remember when he talked about the car break-ins and the thefts, the petty thefts, the major thefts, crimes that you wouldn't associate with the opioid epidemic? But you are seeing that right here in Madison.
Absolutely. These people are breaking into cars, breaking into cars, breaking into homes. They're stealing purses at the grocery store. They're stealing your prescriptions. Your family members are also perpetrating these crimes. It's not just us that are worsening the death, but also some child abuse and sexual assault. It's all related to these
Joe Berryhill, I spent some time with you as well. People end up with toe tags in your place of business. You end up on the scene many times when MC may arrive and try to revive a patient using Narcan or whatever means available. Tell me about your purview. What are you seeing from the coroner's office?
From the coroner's office, our perspective is that in 2017 alone, we've had 65 confirmed drug-related deaths. And we still have approximately 15 to 20 cases where we're still waiting toxicology testing to be returned to us from the state laboratory. And we expect that number to rise somewhere between 72 to 75. Now, to put that into real perspective to how big the problem is, we're seeing a drug-related death occur once every 5 days in Madison County.
On average.
On average.
Once
for
every 5
2017.
days. And what do you see? Are you getting to the scene and you know immediately what you've got?
Many cases, though they may involve different drugs, we typically see opioids as the primary drug of choice. And 2017 seeing fentanyl as the dominant drug of choice in the toxicology test when they were returned. Many users will smoke the drug, snort, or use IV injection methods. Oftentimes, people are still found with needles in their hands and many times in their arms.
My naivete in talking to these professionals about that, I said, how in the world does this fentanyl patch, how is this translating to an overdose? You get to the scene and you know immediately. What are people doing with an opioid patch or the fentanyl patch?
In some cases, what we're seeing is on the patches, they will actually place it in between the teeth to bite down to break the transdermal time-release seal. That way to get a greater high out of basically sucking the fentanyl out immediately versus being released over a period of time.
And it doesn't take much at all, does it? It's almost
It
just
does not.
dust.
No, ma'am, it does not at all. Once inside the system, anywhere as little as 4 to 3 nanograms for fentanyl can result in respiratory failure and arrest.
Mr. Telly Lanier, you, in a different way, if they aren't many times ending up in Tyler's place of business, thankfully they're ending up with you. Tell me about, from your perspective as a substance abuse counselor, who you're seeing and how you are able to be part of the solution.
Now we're seeing, one thing I want to point out to a lot of people that this drug doesn't see color, it doesn't see age, it doesn't see socioeconomic status. We're seeing everyone from as young as 12 to as old as 65. It's around the board. We see opiate use in every community, in the most important community to the poorest community. It does not matter. I'm sure Mr. Mayor Hill can talk to each one of those communities. And in treatment, when we get people in treatment, we're seeing now where it's a new type of person coming into treatment. In the past, we saw a lot of people that were referred to treatment through law enforcement. And then when the law enforcement do their job, they have to come to see us for treatment through drug court or through other means. But now we're seeing a large number of the, I guess, homemakers, people of that nature who may have had back problems and got to the doctor and was prescribed a prescription medication to treat their pain. But with that, they become addicted, and now they have to come see us for treatment.
You busy?
Very.
How many patients do you see a day?
With group, we see basically about 60 a day through group means. People coming in for assessment, roughly around 25 a day.
Okay. Still, those numbers don't quite jive with the amount of opioid abuse that's out there.
Yes. The thing is that 90% of the people that come in for assessment are court referred. They have to come in. So if the number, just imagine the ones that are not court referred out there that are not seeking help. So we only see a fraction of the people who have this opiate addiction that come in and seek help.
I'll be following up with you in just a few minutes. Now, Ms. Krausen, got to ask you, as a retired pharmacist, a lot of people ask the questions. When someone comes in with an RX, they have a prescription, and then another person would come in and another person come in. Do you see any kind of similarities when you see one particular physician perhaps writing the same prescription over and over again?
Well, in Alabama, as well as I think 49 of the states, we have a drug monitoring database that pharmacists are required to log those prescriptions into the state database. Physicians are required to log them as well, so that if you look in the database, you can tell if this person has been doctor shopping. And that database now, fortunately, goes across states. 35 states will share data. So our friends in Tennessee, Mississippi, and Georgia, you can get data from that as well.
So as a pharmacist, you would see people coming in frequently?
Yeah. it's referred to as doctor shopping. They will go to different physicians and get prescriptions for pain medication and get them filled.
Is there any requirement on the part of a pharmacist in Alabama to report any suspicions you may have that may not be contained within the required paperwork?
Well, if the pharmacist thinks the prescription is forged, or they know that something is quite amiss, they'll usually call law enforcement, and if they can, they'll try to detain the person by asking for different questions and stuff to get them to stay there until law enforcement arrives.
Gotcha. Agent Hamilton, DEA.
Yes, ma'am.
Tell me about your role in the opioid crisis, what you're seeing on a daily basis.
Okay, so I'm the senior agent for DEA here in the state of Alabama. We have 4 offices, one here in Huntsville, Birmingham, Montgomery, and in Mobile. And my job is to set the priorities for our agents, with their investigations. And obviously, opioids is probably the top priority right now.
How many investigations do you have right now that you're working actively?
Actively?
Mm-hmm.
A couple of hundred, easy. I'm easily a couple of hundred.
And that is within what purview? The entire
Statewide.
Statewide,
Yeah, statewide.
200.
Yeah. Just since 2014, our tactical diversion squad, that's one squad, and our diversion investigators, those are individuals who are non-gun toters. They're predominantly regulatory in nature with regards to their investigations, have criminally investigated and prosecuted federally 12 medical doctors in the state of Alabama. That is unheard of. It's the kind of statistic that should have national coverage. And that's not including the Dr. Murphy that's being investigated, and it's not including the one in Montgomery that you're talking about that we're currently investigating, because those haven't been convicted yet.
Mm-hmm.
They will be. And one of the other priorities that we've set is that we're strictly going after, not strictly, we're going after really hard individuals that we charge with what's called delivery resulting in death. Chris, in his opening remarks, we're discussing an individual who died in Tuscaloosa back in 2013. A side note to that investigation, or to that case, is that we, DEA, indicted the guy who delivered the drugs, or sold the drugs to that kid, and charged him with delivery resulting in death. And he's currently doing 20 years in federal prison. We've been very successful with those types of cases. Just in the last year alone, we've done, I think, 4 here in the Northern District of Alabama.
The DEA does not work alone. How does it work in tandem with other agencies, with pharmacists, with all the players involved?
Oh, especially with the opioid epidemic, we have strengthened our partnerships, especially with the FBI, the IRS, HHS, and anybody else who is willing to assist. The partnership that we have with the FBI is the best I've seen it in 22 years, especially here in the state of Alabama, because we cannot do it alone. I have one group of 10 guys who are dedicated to nothing but criminal investigations for DEA registrants, pharmacists, and doctors. Just 10 for the entire state of Alabama. And we are probably still in the top 5 for overprescribing by doctors.
So how does this work? How does an investigation begin, whether it be through you or through FBI or on a local level through Madison Police or Huntsville Police? How does it actually start? Is it with a tip?
Yep.
Starts with a tip.
You name it, and that's how it started. We currently are working a case where it started with a tip. It came in through a DEA tip line. We've worked cases where a local PD has called and said, hey, you guys ought to take a look at Dr. Smith, throwing that name out there. I constantly go by, every morning at 9 o'clock, and there's a line around the corner waiting to get in. Pharmacists call us and tell us, hey, Dr. Jones, a lot of his patients are coming in here, and every single one of them have a prescription for OxyContin. You name it. That's how a case starts. You name it. A patient calls. A family member, has a death, and they find, 20 prescriptions from the same doctor, and they all had, some type of narcotic involved.
And doctors are patrolling themselves too, right? Through
Oh,
the
absolutely.
State Board
Yeah,
of
that's
Licensure.
a very good point. Yeah, we've actually had several doctors call us and say, hey, you mind taking a look at one of my colleagues?
So it does help when it comes to the licensure aspect. I had questions initially when it came to this opioid crisis. How are people getting addicted? Who are the people getting addicted? Sherry Squires, what is it physiologically as a physician that where one would become addicted to an opiate? We saw the testimonials here where it said it just took me one time, the mom who said all I needed was that one and I knew I was hooked. Opioids, for some people, opiates will make you very nauseous the first time around, and certainly you don't want them again, while others may become immediately addicted. What is it physiologically? Who's the profile? Who is the person who becomes addicted?
That's the hard thing, is that we don't know. You know, everybody is different, but there are people who are much more susceptible, and that's what, as a prescriber, you have to be very responsible, because you don't know whether the person that you're prescribing to is someone who is more likely to become addicted. And that's why it's incumbent upon us as physicians to be responsible in our prescribing. I know my college, the American College of Emergency Physicians, has advocated, and most of us have adopted policies in our department where even if you come in and you've got, you know, a broken arm or broken ribs, you don't get a whole month's worth of narcotics. We prescribe a very limited amount, usually 3 days worth, and only what you need. I don't think I've ever written a prescription for OxyContin, the longer acting ones. We use the much shorter acting ones that are available, and on a very limited basis. So we also have access to the drug monitoring program, and we can check to see whether someone is an abuser, has prescriptions coming from other places and other physicians. We can't get those from all the states, but we usually can check our patients to see whether they have tried to get other prescriptions. We also have been mandated in Alabama to do continuing education every year on opiates and opiate prescribing practices.
We go into the position now, we can get a quick strep test, we can get, you know, so many things in just a moment's notice. Is there no way from a provider standpoint that there can be a quick swab to know this person should not be prescribed an opiate, or this person can?
We wish there was. We also wish there were better alternatives, because, you know, there aren't a lot of great alternatives. There are alternatives, and, you know, for people that need pain relief for longer times, you know, we want those people referred to a pain specialist, someone who can use other methods of pain control, physical therapy, and other things along with medications, because medications aren't always the answer.
How are the kids? How are the adults? How is it being purchased? How are they getting these opiates if they're not getting it from, you know, from a medical provider? We've heard, you know, from these people here, they're getting it on the street.
Well, the sad thing is, one of the first narcotic addicts I ever met after coming to Huntsville was a man who was doing repairs in homes, and I just asked him, how do you get so many drugs? And he said, I steal them from places where I work. I go in people's medicine cabinets, and this was long before the current crisis. So often they steal, they buy them on the streets. I had one patient tell me he took his grandfather's opiates. His grandfather had metastatic prostate cancer, but that's how badly he wanted those things, is he would steal them from his dying grandfather, and that's just what they do.
Interesting. And so that's thief, you know, I guess theft, going into homes or finding a relative or something like that. Are you finding it out on the streets like that as well? What are you hearing from the kids? You say you're looking at it in schools.
We do. What we're seeing in the city of Madison, and I'm just speaking for the numbers in the city of Madison, the average overdose victim that we see is white, male, 18 to 28 years old, living at home with parents, some college, usually either unemployed or underemployed. It's reflective of our city, but that's not to say it's limited to those people. What we are seeing, the trend is they're getting younger and younger and younger, and that is our concern, because if you think about it, we're getting it in our own homes. That's where our kids are getting these drugs. We actually had an arrest of a mother who gave another child one pill, but that one pill caused her to overdose, resulted in an emergency room visit, and it resulted in the arrest of this, as we called her, a soccer mom, for being a drug dealer. She distributed narcotics to a child.
So you say, though, typically not the soccer mom, 18 to 28, white male, underemployed or unemployed. Are you all seeing that across the board from FBI, DEA? Are you all sharing that same profile, white male, 18 to 28, or who are the profiles you all are seeing?
Probably that's very common, but you also see moms, younger people, older people. It's and all economic barriers, as the others have said. There's not a typical. That is probably the most common, but nobody's immune.
Nobody's immune. Everyone agree? All different profiles.
Not only from the abuser standpoint, but also from the distributor standpoint. I mean, it's broken all racial boundaries. It's broken social boundaries. You name it. I mean, you're just as likely to see an African American distribute methamphetamine, heroin, crack cocaine as you are a Caucasian these days. Whereas years ago, 20 years ago when I started, you could put each drug in a racial stereotype, I guess. Not anymore. It's broken all boundaries.
Knows no boundaries at
No
all.
boundaries.
I want to bring in our viewers right now on WAFF.com and on our Facebook page. There seems to be a debate going on about Suboxone as opposed to methadone often is a treatment option. This question is about Suboxone and its use in rehab. I happened to talk to an individual today who is being given Suboxone to come off this opiate addiction. She says it is much better than methadone. When she was prescribed that a few years ago, she said this seems to be working. From a pharmacist, from a physician standpoint, can you all address that? And something happened today, March 1, in allowing, am I correct, Medicaid covering that in, I guess, in-house with some kind of supervision? I don't know if you all are familiar with that or have any background, or your thoughts on Suboxone. That seems to be a hot topic right now. Again, Suboxone being used in rehab.
We don't use Suboxone.
You don't use
Currently
Suboxone?
Yes.
Suboxone is typically used especially if somebody is going through withdrawal. It will help them get through withdrawal, and then they can either stay on it or they can start reducing the dose down to completely get off of it. Whereas methadone is every bit as addictive as the drug you're trying to replace. And with methadone, the person has to go to the methadone clinic every day and take their dose there at the clinic. With the Suboxone, it can be prescribed. Physicians have to have a special license to be able to prescribe it for patients who are trying to be treated for addiction. A physician could prescribe it for pain without that special license, but not for treating an addict. And they can get a prescription and take it at home. They don't have to come to a clinic every day.
So it's more advantageous? Is that what any of you professionals are suggesting? That is an advantageous way to help with this addiction in the weaning process as opposed to going cold turkey?
I would not suggest anybody going cold turkey. It can be life-threatening.
Well, that's interesting. Okay. Stephen wants to know, while I have you, Ms. Croson, are you required as a pharmacist to fill an opioid prescription if someone walks in and wants it filled? Can you refuse?
if you think the prescription is forged or there's something, a lot of pharmacists will say, I'm sorry, we're out of that drug. We don't have any right now.
Mike can answer that a little bit better. I mean, DEA is the one that issues, a pharmacist or, a registration number. And DEA views it as they have an obligation to not fill it. If they feel like the doctor prescribed that drug without a legitimate medical need, they have an obligation not to fill it.
So they can refuse it right there,
Yes, absolutely.
on site.
Yeah. Now what Ms. Croson is saying, though, for her own safety, she's going to
Yeah,
find
I
a
was
way
gonna say,
not to do it.
a
you know what
nice
I mean?
way to say it.
Nobody expects her to be a police officer and act as a law enforcement official. I mean, they're going to say, hey, I'm sorry we don't have it. But, yes, they have an obligation to come up with an excuse as to why they can't fill it.
I talked to an individual last night who said that he was addicted to opiates and he did go cold turkey. You said don't do that because it can be life-threatening. True? False?
You don't really die from opiate withdrawal. Like the people in the movie said, and patients have told me, you wish you were dead. Opiate withdrawal alone generally will not be fatal. It's fairly miserable, not fairly, it's miserable. But other drugs like the benzodiazepines, the Xanax, Ativans, Valiums, that family, it is potentially fatal to withdraw. There's a greater chance of, prolonged seizures with what's called status epilepticus and respiratory arrest and things like that. With opiate withdrawal, it's more just that you are absolutely miserable and just so desperate to get that next dose. It is hard, no question.
So Chief Jernigan in the beginning talked about, the major problem he shared with me last week, that the Madison County Jail is perhaps the largest mental health facility in North Alabama because of the number of people there who are not only arrested for these petty crimes or these major crimes, but they're there and have the ancillary addiction of opiates. Tell me how this all comes about, because they're out there. If they're stealing, they're in jail. They certainly could not hold down a job. So from the perspective of counseling, how does that work? How would they get into counseling if they don't have a job, don't have insurance, and don't have an avenue by which to pay for it?
Well, I can speak for our facility alone. We have a sliding scale fee to where we look at your income, and then based on your income, that's where we base your payment on.
Yeah, but what if you went out and just, you hawked something and you've got $500? I mean, what if you don't have a job? How does this work in the society if you need help, but you have no means, no insurance, no nothing to pay for it?
There are other programs, other entities out there that will help people pay for their treatment. As well, there are some treatment facilities that are free. If you're homeless and things of that nature, Salvation Army, places like it have programs in place that would help you get treatment. The other thing with as far as being arrested and in Madison County Jail, we have a Madison County mental health liaison that works closely with the Madison County Jail, who will go in and do assessments in the jail and also let the inmates know their options upon release with treatment.
So tell me about what's in the jail. What percentage of people are there and have an opiate addiction?
I might have to.
Any idea?
In the jail, honestly, I don't know how many she sees. Our jail liaison, I don't know how many she sees a week, but I can tell you it's a large number now. The number is steadily going up, like the movie said. The number is steady rising. We see plenty a week, like you said earlier. We stay busy, so it is steadily rising. But we also like to get in there and let them know their options upon release, and also their options while they're there. You may have someone who may be going through withdrawal, who may have a lengthy stay in the county jail, maybe 6 months or so, and so we will let them know their options while they're in jail as well.
This next question is for Agent Hamilton with DEA. Some of our viewers are writing in saying marijuana is key to getting off opioids. And with the increase in legality among some states legalizing marijuana, Is this a legit solution?
Absolutely not. It is an absolute farce. And the same people with those fancy letters behind their name, like PhDs and MDs, are some of the ones who are peddling that crap. Absolutely not. Part of the problem, part of the reason we're here today is because we've destigmatized the use of drugs. And that's one of the things I keep hoping that somebody's going to bring up, and I haven't heard it yet. Folks, we don't stigmatize it enough. We've allowed our youth to be tricked, to be fooled into thinking it's okay, especially when it comes to marijuana. And if you remember the video, every single one of them, I think but one, said it started with marijuana. There is absolutely no legitimate medical use for it, period.
They start with marijuana, so what's being done on the local level? Tell us about what you all are doing in law enforcement to keep this out of the hands of the youth or the soccer moms and everyone in between. If it is the gateway to these opiates where people are chasing the dragon. Anyone in law enforcement? Where do we begin with this potential solution? I mean, it's a vicious cycle. Where do you start? How do you tackle this?
Are you discussing specifically marijuana as the gateway drug?
Well, we can start with marijuana. We can start with anything, possible solutions.
Look, I'll start it with marijuana. Law enforcement's not the answer. It starts with these folks out here. It starts with the parents, and it starts with the schools. You cannot buy into this crap that marijuana has a legitimate medical use. It is an absolute farce. And the people that you see on national TV who keep spouting this, I promise you, have a financial reason for doing so. Look at Purdue Pharmaceutical and how we got to where we are with the opioid epidemic. Billions of dollars they gained through fake advertising, through BS science, saying that it was non-addictive. And it's the same thing that's happening now with the marijuana industry. They're marketing to kids with these little chewables. I mean, if the tobacco industry was doing today what the marijuana industry is doing, people would be in an absolute uproar. I mean, they'd be raising arms going after the tobacco industry. But for some reason, for some god-awful reason, it's not happening with the marijuana industry. And in Washington State, in California, and in Colorado, that's how they're marketing marijuana. They're selling chewables, they're selling brownies, and it's got some of the most potent THC that our country's ever seen. And we've yet to see the long-term effects that it's going to have on our youth.
Yeah, Brett, tell us, it's not just the medical marijuana, they're peddling recreational use.
Oh, absolutely. Yeah, and I keep saying medical.
But it's like booze.
Yes. Yeah, I mean, they're saying it's okay because it's recreational. It's safer than drinking a beer. No, absolutely not.
So what are you telling these parents, these teachers out here right now? What do you want them to know?
If you're a teacher, obviously you can only go so far with your students, but especially if you're a parent, I want you to be nosy. I want you to look in your kids' phones. I want you to look in your kids' shoe boxes at home. I want you to look under their beds and have a good, hard discussion with them about marijuana.
So they are out here, they're watching, they're supervising, they're checking. They find something. What do? How do they begin that conversation? What is a parent to do if they believe that their child is either doing, smoking marijuana or worse, trying opiates?
Yeah, I mean, look,
What's the first line of defense? I mean, who do they call? What do they do? Because some of these parents want to know from any of you, what is the first line of defense?
It's hard to answer that kind of question without knowing how far down the line they are with it. It's a first-time use, and maybe you've got a chance to interdict it at that point. One of the things that I recommend to my friends is going on YouTube and watching this video with your kid. There's another YouTube video called No Dope, K-N-O-W, No Dope. And it's based on individuals right here in Alabama, families in Alabama, specifically in Jefferson County. The individual that Chris is talking about, that father is interviewed in that video. And again, these family members talk about how they thought their kids might have been using marijuana. If he or she is further down that road of drug use, there's some other programs. There are some diversion programs in Shelby County. The DA's office has started a program there where parents can call the DA's office and they can, they can pair the kid up with an officer, and they basically sign a contract with this officer to allow them to come in and search their room at any time. If the parent thinks that, hey, I think my kid might have been out a little bit too late last night, he might have picked something up. And it diverts them out of the legal system, and it kind of partners them with law enforcement, but without that worry of being arrested, I guess, and starting a criminal record. So there's a lot of imagination being used out there, but I don't think the programs have been pushed out into the community. I'm really excited about the one in Shelby County, and I encourage local chiefs and sheriffs throughout the state to really look and watch and see how this one goes. I'm hoping this happens.
Chief, do you have anything here in Madison County like that? Interesting. Duly noted. Duly noted. What else is a parent to do? Tell me about that. I mean, from a parent, should they, immediately go get some tests done? Do they take them to the physician? What do they do?
Well,
What's the first step?
if you suspect that your child is using, I would recommend you can take them to their primary care physician, and they will give drug tests. If not, you can bring them to our facility. We will drug test. There are a lot of great programs out in the community that are tackling this problem. Partnership for Drug-Free Community, Ms. Dunaway, Ms. Candace right there, has a wonderful program. Our facility have a wonderful prevention program and intervention program where if a parent suspect their kid may be using, they can contact us. You can look us up online, or you can look us up on the directory for Wellstone, and they'll direct you to a person who you can bring your kid in for an assessment. And you can also, if you suspect they're using, if you think they're maybe thinking about using, then you can introduce them to our prevention program. We do have a drug prevention program, and it's a great program that's doing some wonderful things. One of the few things we're doing now, we are actually moving on to the college campuses here in Huntsville. The first campus, our first campus that we're going to see is Alabama A&M, where we're going to participate in a new site for the prescription drug take-back, which is a great thing that the DEA partnership and Madison County Police, Huntsville Police, that a program they run, which if you have drugs in your household, people, please don't flush those drugs. It harms our environment and
water system.
Yes, so don't flush them. There are prescription drug take-backs. There are prescription drug drop boxes located in some police stations. My company, we're going to sponsor one prescription drug box that we're going to try to locate in a new precinct here in Huntsville. That if you want to dispose of your drugs, whether it's opiates, whether it's blood pressure medication, expired drugs, it doesn't matter what it is, bring them and put them into the prescription drop boxes and dispose of them correctly. If you, the main thing, if you suspect your kid may be using, I would recommend you have them tested. If you have them tested, then I highly recommend you seek treatment for them.
There are dangers in having them tested, though, as well, because if a parent goes in and it's on their insurance, would it not be logged and listed that this individual was found to have this, and this, and then it follows them the rest of their life?
We have privacy laws in place, HIPAA laws in place that may protect that young person from it becoming, public knowledge that that young man was using.
Okay, so from that point, get them tested, and then they can. I hear so much about the lack of resources and the lack of space when it comes to either inpatient or daily therapy, anything that's available. True or false? I mean, there doesn't seem to be a whole lot of options out there for whether it be an adult or a child when it comes to help.
There are several options. The thing is that a lot of people don't explore all the options. Most of the time when you think about treatment or space for treatment, you think about our facility, or you think about Bradford or something on that level. There are other faith-based treatment out there and things of that nature that a lot of people don't think outside the box. The best thing is to that wonderful phone we have, smartphone, get on that thing and Google treatment facilities or things of that nature. There are treatment facilities that deal with nature. Think about that. I think about one young man that came to my mind who received treatment at a horse facility that specializes in horse
Hippotherapy?
breeding. Yeah, horse therapy and all that good stuff. So just Google, use that search engine, Google treatment. You'll see several options, and some of the options that a lot of people don't think about may be outside of this community. You may have to seek treatment in, maybe another state or another city. So there are plenty of options out there.
John Howell, not everybody is as lucky, perhaps as fortunate to be able to go to the doctor and take someone and find out that way. HEMC may be that first line. You see these, first person, second person, maybe two people together. What do you do from a paramedic standpoint when you see, an individual? Do you take it upon yourself to, from a HEMC standpoint, to get them help or to encourage that?
We do. We always want to try to find a solution for our patients who are seeking health care. We recognize that in today's environment, health care is often provided outside the hospital, but and we want to be a means to facilitate that. But we are looking to get our patients transported to the correct provider, and sometimes that provider may be the hospital emergency room. Even if they will not go to the hospital with us, we want to at least try to convince them of the importance of seeking treatment for whatever their condition is. And I'd like to add that normally, if you're trying to find your children or a loved one treatment, an ambulance is not often the solution that you need. However, if you're seeing that person suffer a lot of drowsiness, if they're hard to arouse, if they seem to have a slower respiratory rate or they're not breathing as fast, you just need to call 911. Out of the nearly 1,000 events that we had last year, we only had to give Narcan to about 600. The other 300 and some people wound up either just being transported to the hospital. Some of them may not have been transported, but we deal with a lot of patients who are just seeking help, and we're trying to get them into a medical facility where they can start that journey.
Tyler, you mentioned outstanding cases from the coroner's office. You're waiting on autopsy results. How important is knowing what's in a person's system so that you can get the word back to others up the food chain, for instance, to DEA and FBI, and then local law enforcement, so they know what's out on the street?
Right. When we think about drug-related deaths, and in terms of autopsy, usually at the autopsy, the only findings that we commonly see, such as opioid-related deaths, are cerebral edema. The lungs will usually be very congested, as well as the heart oftentimes will be dilated. But as far as any pathological findings, they're usually absent, because the opioids cause the body to have a physical response. And we need to look further to look inside the blood to see what drug is present and how much to know how it makes the body respond. And in cases of the opioids, it falls along the lines of respiratory failure. And typically in the state of Alabama, it's taking 3 to 4 months turnaround time to get those answers back from the state laboratory. And that's due to backlogs and just the in-depthness of the system.
But if there's something new that's on the street, for instance, HEMC oftentimes sees it first. You'll know when some new batch has come in, or if it's a bad batch or something's mixed together, correct?
We will, and we unfortunately a lot of times we'll start to see multiple people on the scenes. We have experienced cases where we'll go into a house and we'll actually have up to 3 victims in the house, all from an opioid overdose. We might have one in cardiac arrest, one in near cardiac arrest, and another one that just needs to be treated. So we wind up having to bring a lot of resources in on those cases. But we can usually tell when we start to see drugs flow into our community and become available, and they'll also be clustered, so we see a lot of calls maybe in the same neighborhood.
So how does the line of communication work? You'll see it first, and then how does the trickle-up theory work with others so they will know, because the hospital will see it then local law enforcement, then state and federal? And so that how do they know so they know what they're dealing with and can begin either an investigation or put some kind of stop to it? How does that work? How does the communication work?
As far as the city of Madison, when HEMC is notified that they have an overdose that they have to respond to, dispatch also notifies the patrol unit. We will have a patrol officer respond to that scene. If it's determined that we have an overdose or an overdose death, I'm speaking just in the city of Madison, one of our team will respond, and we will conduct a collateral investigation. If it is a death in the field, our criminal investigation, they'll conduct their investigation, but our team also will conduct a collateral drug investigation. We're going to open it up as if we were going to prosecute a homicide. It's very rare that we can do that, but we're going to follow that drug. We're going to interview everybody on the scene. We're going to look at cell phone records. We're going to go backwards and try to follow where that drug came from.
Wow,
We
okay.
have made multiple arrests using that procedure. We started doing this about 2 years ago when we saw the rise and then the peak of those overdose deaths. And we were successful in multiple operations as far as following it from the death. We don't want to get there. Our goal right now is what we see out here is to see these parents and have the parents understand search and seizure does not apply in your home. It applies to me and these other law enforcement officers and these out here. We have to know those search and seizure laws, but in your home, it's your
All
home.
bets are off, huh?
You better be searching those backpacks, those cars. You better be looking at their phones. You're paying their phone bill. Know who they're talking to. Look at their Snapchat. Look at their Facebook. Look at their Twitter. Know what's going on. If you don't know, you can't intervene.
My house, my rules. You've heard that before, right? And used it, I hope. Let's talk about options for pain medication. We have a question about that. There have to be options out there if these opioids, oftentimes, as we've heard from the Veterans Affairs, National Veterans Affairs Coordinator today, David Shulkin, he said oftentimes these opioids are prescribed first by people who've had back surgery or football injuries or, something else, or chemotherapy or cancer. So, again, what are the options out there people need to consider or perhaps suggest?
A lot of times, initially, the anti-inflammatories, the ibuprofens, the naproxens, Tylenol, those are very effective medications. And when used appropriately or even together, some of them, like the Tylenol and an anti-inflammatory together or alternating, can be very effective. And you may not have to move to a next step. Muscle relaxers are often helpful, and some of those are better than others. Some of those are sort of borderline, but there are effective muscle relaxers that, with an anti-inflammatory especially, can be very effective for those kinds of things, because if you can address the muscle spasm that goes along with the pain, you can reduce the pain. Sometimes an opiate is appropriate for severe pain, for special indications. We'll use them mostly for things like severe shingles, for cancer pain, metastatic bone cancer, for kidney stones, for acute fractures, those sorts of things. A lot of times it is appropriate to use them, but usually in conjunction with other things. And physical therapy has also been shown to be very effective too.
So then the obvious question is, so why aren't those being prescribed right out of the gate? Why not the lesser over-the-counter, the OTCs, as opposed to hitting off with the opioids right out of the get-go?
Well, I think we are seeing that more. At least that's what we're trying to educate. I mean, I had explained that there's opiate education. There's also pain management education going on. And I think physicians are being trained more to do that and to try other things and to explain other avenues and to explain the downsides of opiate prescriptions. I mean, there are a lot of downsides just to using opiates even temporarily. I mean, nausea, constipation, drowsiness, other things. Even
Yeah, so with all that, how do you get addicted? Who wants to take something that's going to make you throw up?
One would think, but there are a lot of people that are very susceptible.
Ms. Crowson, you?
Well, I was just going to say that 1/3 of long-term patients on prescription opioids report being addicted to them. So anything after 3 days, your potential for becoming addicted goes up. And one of the things that I think our audience needs to know is if you do have someone that's on opioids, and a lot of elderly patients, we're seeing a lot of prescriptions for opioids in elderly patients, and they are becoming addicted, is that you may want to keep Narcan in your home, the reversal agent. If you have a known addict living in your home, you probably want to keep Narcan in your home. In the state of Alabama, there's a standing order from the Public Health Department for Narcan, a prescription, so that you can go into a pharmacy and they can sell you the Narcan based on that standing order. You do not have to have another prescription for it. Some of the physicians are actually writing prescriptions for Narcan if they are writing for more than 3 to 5 days of an opioid. It is expensive, so I will warn you up front.
We have been warned. Yes, sir.
Before we move away from the prescribing subject, I want to throw out a couple of stats real quick. Worldwide, Americans use 80% of oxycodone. 80% of the world's oxycodone that is produced, Americans use it. If you look at hydrocodone, it's closer to something like 97% of the world's hydrocodone. You mean to tell me Americans suffer from more pain than everybody else on earth? I mean, it sounds like we're a bunch of wimps when you put it that way. And so my point is, if you've got a family member who gets a surgery, has a surgery on his shoulder, who has something removed from his knee, his meniscus, and I'm using that as an example, and a doctor prescribes hydrocodone or Oxycontin, you need to be raising hell. There is absolutely no reason why. And that's exactly what happened to me. I had my meniscus taken out a few years ago, after I got shot, by the way. And oh my God, you would have thought, I was dying of something, after getting shot in the rear end and coming out my hip. And I'm trying to make a joke here. I'm not doing a good job.
Ha ha.
Yeah.
No, but what you're saying is you want to empower everyone out
Yes.
there. If they have an ailment, what
These
are they
drugs,
to do? Be your best advocate and say, I want
I
nothing.
don't-
I want a leave.
Yes, exactly. Tell your kid to suck it up. If all it is a minor injury. If he gets a wisdom tooth taken out. No, absolutely not. Should a doctor be prescribing an opioid? So.
Do you all agree? Everyone agrees. No one should be prescribing that. Okay. It's about 8 o'clock. Do you all have questions out there that you would like to address this esteemed panel? If so, please come to the microphone. Know what you want to ask specifically about the opioid crisis, and perhaps go ahead and address it to these individuals. That's why they're here. They want to help you. They want to inform you. They want to empower you. So they're here to answer your questions. Do you have any? People at home, if you're watching on Facebook or on WAFF.com, please go ahead and get those questions in, and I will see them, and I will be happy to share those as well. Yes, sir.
Question. You say that seems to be the oxycodone and other things seem to be the first line of prescriptions that doctors sometimes prescribe. I was looking on the internet, and I know that could be a bad thing, but I thought I saw something that there was some sort of a kickback or financial incentive for doctors prescribing those lines of drugs. Was that something I found? Was that a true thing, or is that fake news?
No, yeah. So several of the doctors that we've convicted over the past 2 years, that's one of the things that they've been convicted for is, in addition to not only prescribing narcotics without a legitimate medical need, they've also been convicted of medical fraud. And I'm not sure of the term here, but also having had stock in a certain drug company, and that company giving these doctors incentives to prescribe a particular drug. That's one of the things that we've seen over and over again with a few of these doctors, is that for whatever reason, somehow this a company develops a partnership, with doctors or a practice in particular, and they'll prescribe a particular narcotic over and over again. So that's probably something you read. This was particularly in a case, or specifically with a case down in Mobile, Alabama. It was Dr. Couch and Ruin. It was the first RICO charge that was successfully convicted of in the U.S. I think 2 years ago, I believe, that FBI and DEA did together.
So
And
it's a
that's
big
exactly what they were
pharma
doing.
problem?
I'm sorry?
So it's a big pharma problem?
Yes. Yeah.
Yeah,
Absolutely.
On the sales rep side, what we'll see is because they're making money off the doctors that they're supplying the drugs, they will work the kickback scheme too, and that could be anything from cash payments to actually putting an employee into the doctor's business that the doctor then gets to use, but that the sales rep's paying for.
Really?
Gives them a free employee.
Did everyone hear that? Bring up the microphone a little closer, Agent Stokes. So Agent Stokes is talking about how this works from big pharma to the doctor's office and a trickle-down theory.
Yeah, I'm going to push it down a little bit lower down to the sales reps who are visiting all the doctors who are getting their money from the prescriptions and the prescriptions that the doctors are writing. They'll do kickbacks. Sometimes it's in the form of cash. We had one doctor that was recently prosecuted who had $670,000 sitting in the cabinet inside his house. He had a person that was supplied to him by the sales rep who was there as a consultant for the doctor. And what he would do is every time he wrote a prescription, the sales rep would justify this consultant being there in order to advise the doctor. But the doctor was writing so many prescriptions for this particular drug to get his kickbacks that it would have had to been, it was like they couldn't bill enough because it would be like 48 hours in a day that this consultant would have to be getting paid an hour a day for these consultations. So we see that too. We see that they supply employees. We see kickbacks on money, vacations, you name it.
Where do you find this out? Post, when something occurs, when there's a death? I mean, how does this investigation begin that you can actually put a stop to it?
Brett addressed it earlier. We get a lot of tips on some. Also, we have the databases that are really good within the state of Alabama that we can see how many prescriptions doctors are putting out. And it just takes a while to get around to those investigations. When we're looking at from the healthcare fraud side, we cover the healthcare fraud side. DEA covers the diversion side with us. And we bring IRS in to go after the tax evasion side of the house, too.
Mm-hmm. It always hit them in the pocketbook.
Well, some of these doctors, when you're talking about pill mills, you're not only talking about patients that come in with insurance, which is our insurance fraud side of the house, but you also have people who don't have insurance that are coming in to get their pill prescriptions, and they're paying $450 in cash for an office visit. Mm-hmm. So like this doctor I was talking about, he would end every night, he'd go through the cash register and pull just $100 bills. So we ended up recovering $670,000 in $100 bills just from what he'd pull out of the till at night and take home with him. Like we throw change in a coin basket, he would throw $100 bills in the cabinet.
So how does this investigation with DEA, locals, federal work? You have a physician, you suspect, you have proof, you're going in there, you make a raid on this practice. What happens during that? You get a lot of paperwork in that raid. What happens, and what about the timeline for prosecution, potential prosecution? And this office is still open writing prescriptions.
Paperwork-wise, I have 3, what do you call those things, pods? You know, I'm talking about the storage pods that you can rent and bring to your house. I have 3 storage pods parked in my parking lot, full of nothing but medical records. It generates a tremendous amount of paperwork, and then you have to hire, medical experts to go through these medical records to prove that most of these prescriptions are being prescribed without a legitimate medical need.
In the meantime, the physician is still practicing, right?
Look, I mean, thank God for the 4th and 5th Amendment. We can't just lock somebody up without any evidence. So there's only so much we can do with regards, legally. as far as trying to stop the doctor immediately once an investigation starts. Oh, believe me, I mean, we all sit around the office sometime thinking, what more can we do and how quickly can we do it, because we know patients are dying. We know it. But there again, thank God for the Fourth and Fifth Amendment.
I want to ask a basic question. How can someone out in the audience determine whether someone is addicted to opioids? What are some of the telltale basic signs? Anybody from experience? I mean, you physician-wise, you've got counseling-wise.
From their behavior changes early on. When we talk to people that come into the emergency department, and admittedly I usually see them very late, not in the early stages, but what family members will say is that we ignored a lot of things that we should have seen. Being late, not being where they're supposed to be, having car accidents, missing credit cards, just a lot of things that in retrospect they were like, oh my God. But just excessive sleepiness, anything that you notice that's just different, missing school, just
missing work.
Injuries that look like maybe they're not the way they should have happened. People have been known to hurt themselves. We've even heard of people saying that they hurt their animals and get things from veterinarians. It's people do desperate things to get medications. You just have to be aware.
One of the first things that a parent or someone that you're living in the home with someone who is addicted, one of the first things that I've heard the parents tell me is his physical appearance changed. He became unkempt. He was always very well dressed and cared about his appearance, but that was one of the first indicators. They just saw that gradual change, and then the next thing they saw was a change of associates or a change of friends. The kids they had grown up with a certain group of friends and played ball all their lives, and then all of a sudden they shunned those friends and they had a different group, or they introduced to a different group. Those two things is what we see in children or teens, preteens, younger people. Those are two great indicators to look for.
Yes, sir.
And one last thing that no one ever thinks about, and it's so odd when we're talking about prescription drug abuse and opiate abuse, is your young person's bathroom habits. I know that sounds strange, but constipation comes with it. So if you see a young person who's using a lot of laxatives, and they normally don't use a lot of laxative, that's a big warning sign for prescription drug abuse.
Who knew? Okay. Ma'am, go ahead.
Yes. So just as kind of a background, in our state, we refused the Medicaid expansion. We decreased our mental health budget by 30% in 2009 and 2012. We have fewer psychiatrists per capita than any other state. In regard to that, because I guess I was a little bit disturbed in hearing in the video the mother saying she was just so happy she could have her daughter arrested so her daughter would be safe. That perspective to me is, very sad. I understand why she felt that way, because she didn't want her daughter to die, but we need better options. And I know there are some options, obviously, in our city for people to get health, but they're sorely lacking. I've had people living with me who are trying to get sober. I've taken somebody to Huntsville Hospital who basically could only stay because they said they were going to kill themselves, and so they got to be able to be committed. There's no ability to commit when you know somebody's basically going to end up killing themselves. I'm just bringing these things up because I understand we don't want our kids to start. God knows I don't want my kid to smoke pot. I don't want my kid to even drink. I honestly think the drinking is what starts it. But there are so many things I think we need to be doing besides, obviously, don't do it. Your life is going to turn into an entire mess. But, especially from Huntsville hospitals and that kind of thing, I really want to hear what you can do in the community, especially Huntsville Hospital as a pillar of the community, just start helping with the crisis in the community.
It's tough because a lot of times, at least in my world in the emergency department, when I have a patient, they have to want to be helped. I don't have the right to just put them in the hospital and fix them. So if they don't have a real indication for a medical admission or something like that, I mean, you know, yeah, if you're comatose, yeah, we're going to put you in and you'll get you'll be hospitalized. If you're having a medical problem, if you have an infection, you'll be hospitalized. But if you don't have a legitimate reason for a medical admission, and a lot of times these people will even refuse that. But
and we have no Baker Act.
No, we don't. And I would love a Baker Act. I've said that's going to be my swan song, is sitting in a government
I'm from
campaign
South
for
Florida,
that.
so I'm familiar with
We
at
would
least
love
what Florida
that.
has.
The other problem is, and Mr. Lanier can probably talk about this more too, is that there's this dual diagnosis thing. You know, the depression and, well, which came first? The addiction problems and the drug abuse
Are they
problems.
self-medicating because they don't feel right?
Right. And so, you know, it tends to be, well, you know, that's not something that the court will commit them for because it's drugs. It's not a mental illness. Or they, you know, on the mental illness side, it's, well, we won't, you know, they need to fix their drug problem first, or the other way around. And so you end up in that battle. And you can't commit them unless they've actually done something to harm somebody else or harm themselves. They can't just be saying, you know, well, I think I'm going to overdose.
So what's the
really
answer?
Tough.
What is the answer for all of you all at this point, from a community standpoint?
From my standpoint, I think that I've changed the way I think about this a lot over the last few years. There isn't a one stock answer for every addict out there. There are lots of different, like you were talking about, there's faith-based programs, there's the Suboxone, methadone, drug-assisted programs. In the medical literature, those are what is shown to be have the greatest success rate. But there are lots of different alternatives, and I think that, at least as a medical profession, we need to be open-minded to all of those. And I think as a public, we probably do too.
Go ahead.
First, I'd like to commend Agent Hamilton for the knowledge of the pot. My son first started smoking pot in the 8th grade. I knew about it and tried everything to get help. So I'm very grateful for everybody being here. But I don't know. I'm getting information, trying to walk forward. I buried my son in November. And he died of an opiate addiction.
So sorry.
Thank you. But going forward, knowledge is power. So part of the reason I'm here, he did try Suboxone clinics, and there wasn't enough open that he couldn't get in. He had a pending criminal charge, and he wasn't allowed in one of the rehabs. He got expelled from a rehab for using drugs in a drug facility, trying to get rehab. So that would be my question to the panel. Everything is full. I had insurance on him, so he could get in if he could. He told me he was going to die if he didn't get help. I don't know how much he tried, because it's exactly what that video, wow, eye-opening, I saw. I saw in my son. The signs are exactly sleeping, couldn't keep his eyes open, talking to me, acting silly, dancing with me in a parking lot. That is not my son.
So you found a shortage of help out there.
Yes.
You knew and you wanted to get help. He wanted help, but you could not be linked to it.
Yes, he died August 2nd, the first time, and thank you to the wonderful medical staff that revived him with Narcan. And I was told he had 3 times the lethal dose of fentanyl and survived, miraculously survived, only to be buried in November. Lack of help for all the parents and everybody here. It's
So was it a shortage of beds? Was it a shortage of counseling available?
You know,
From a
I think
physician standpoint, does a parent have that kind of assistance?
I don't know. I took him, I thought I did the right things. I locked up his phone. I took him to Neves Davis in Huntsville and got him drug tested, because they'll do it for you. I did everything I thought I could. I was probably the one that was looked at as crazy because I followed him around everywhere, knocking on neighbors' doors, trying to find my child to get him home. Lack of knowledge. I think this is wonderful that you're doing this because it is a lack of knowledge, and parents sometimes don't know what to do. I called the police on my son when I found him with drugs. He tried to run me over with the car.
But how old was he?
He was 25 when he died.
So he's an adult. So what does one do if he had been under? You know, if he had been a juvenile, that's one thing. But as an adult, as a parent,
he was a juvenile when I first started, and tried to get him help. He was actually taken to Bradford because I kicked him out at 18 because I was trying to do the tough love and I couldn't do anything with him, and he came to my house and he was scared and his heart was beating out of his chest, and I said, you can't stay here like that, I'll take you somewhere and get you checked out. And I begged him. He was 18 and he agreed, and the drug counselor at Bradford told me that, and that was the first knowledge I had of the big problem.
So what would you like to address the panel as far as a question?
I would like to know where the help is for the parents and what other steps other than what I did you could do.
So my name is Chris Hoffman. I'm with the FBI. I'm the ASAC, Assistant Special Agent in charge. First of all, I want to condolences to you. You did everything a parent should do. You tried different techniques, tough love, good love, whatever it takes. You tried everything, and it's not your fault. It's the drug's fault. We have employees in the FBI who have adult children who are addicted to drugs. FBI agents and support personnel who are struggling with this very same problem. And the phenomenon I'm going to tell you about is we're behind the power curve. Addiction it's like a volcano, and we're trying to stuff the lava back in the hole. It has happened so fast that we don't have enough facilities. We don't have enough psychiatrists. We don't have enough counselors. We don't have enough the drug treatment programs that Mr. Lanier was talking about, because we haven't caught up. It happened to us very quickly, Brett. I mean, I don't know how
100%. Yep.
It was the genie out of the bottle, and we are trying to catch up. All I can say is, if you have pills at your house tonight, package them up and take them and get them disposed of. That's the first step. Be that nosy parent. And if you are having someone you're already down that road in this addiction, just be persistent. Be the squeaky wheel. Do everything you can to get that person into any kind of facility. But it's not that people don't want to help. We don't have enough. We are just now, as a nation, starting to address what are we going to do about the opioid crisis as part of this, this panel time. But the problem we have, the reality is, it happened so fast. We just haven't caught up to address it.
No, that's 100%. I mean, ma'am, you did everything you could. And the bottom line, he made the choice in the end.
You all agree with these? Anything else? We're running out of time. Any other comments and thoughts you want to?
And I would just say, do what she done. Make your voice heard to the people that are higher up, to the politicians that may be cutting this mental health funding. I'm in the field. That's my field, mental health, y'all. And I feel the funding when it was cut. And we know there's a need for more beds and more facilities, but we can only do so much with the money that we have. So that's when you have to make your voices heard, and you got to go and you got to talk to your politicians, your representatives, and let them know that you want to see more funding in mental health. I know that's a big thing in the news right now, is mental health funding. And we need it, y'all. If you all knew half the things that I see and that I know, you'll know how much we need mental health, but not only just through serious mental illness, but through drug-induced psychosis that comes about. We need treatment for our young people and just everyone. So
because they are co-occurring. You
Yes.
don't know which came first. It's a chicken or
Exactly.
egg question. Again, we need to wrap up. I see we have one question here. Do you have a quick question, ma'am?
Yes. What do you do for a family member if they're addicted to opioids but they're an adult? They're not a minor.
they're going to, number one, they're going to have to want to get help. You can't make them go get treatment, but what I would do is everyone watched the show Intervention, I'm sure, or whatnot. I would bring everyone in that loves that person and beg them to go and seek treatment and get help for their addiction.
Any other final thoughts? Agent Stokes, do you want to start?
Don't let this stuff in your house.
Sherry?
Be aware of your family members, your loved ones, and do everything you can if you see something early. And sometimes, like she said, it's not enough.
John Howell?
I hope you don't ever have to call 911 and do these things that all these folks are recommending, and you may not have to for an opiate overdose addiction.
Officer Taylor Duncan.
As the parent of a drug addict who has now recovered, but will always be a drug addict. We may recover, but we will still be there. It is important to know that what you did was everything you could possibly do. You reach out, you identify, you point in the right direction, you make recommendations, you make rules, you cut them off, you love them. You hate the addiction, but you love those children. Do not give up.
And from the coroner's perspective, that's something that's very important, is that no matter where you are in life or battling the addiction, never give up. Because every moment that you have is precious with somebody, and once it's gone, it's something that can't be replaced.
I just want to remind everyone that recovery is possible, y'all. Recovery happens every day, number one. The next thing is to educate our young people. That's where it starts. An ounce of prevention is worth a pound of cure, y'all. Educate, educate, educate. Show your young people this movie right here. Then educate them about the different drugs and dangers of drugs and what can actually happen to you if you use these different drugs.
I will just reemphasize, get any unused prescription medications out of your house. If you've got someone that's on them that has a terminal illness, lock them up. If you have a child that gets a prescription for opioid type drugs, you take care of them and you give them out on the schedule they're needed, and you might consider doing that same thing for a spouse.
Also, I'll end it with this. I mean, be vocal about these things. Talk to your legislators, send them emails, make calls. Last week, look at AL.com. An article was written by someone that does some of the editorial writings for them. And they stated something like the legislation, state legislation, was a bunch of cowards for not passing the marijuana legalization bill last week. Did you all know that there was actually a bill before the House last week? Yep, here in the state of Alabama. We narrowly missed it. I mean, we missed a bullet here. And then AL.com has the audacity to allow an article be written that they were a bunch of cowards for not passing it. Be vocal about these things. Don't sit passively by.
The conversation will continue here and on air. Tomorrow night, we will have a conversation with a patient, a former patient of a doctor in Lewisburg, to learn more about how this addiction process worked, how a prescription was written for a year, how this individual got it billed every 28 days, and exactly what that individual is doing now a year later. And then next week, I'm going to be following up with one of the women who I watched last weekend, one of the two who overdosed in a parking lot in 5 Points in Huntsville. She has been found, and she wants to share her story, and I think you will find it extremely compelling. She's a very brave young lady, and I hope you'll be tuning in for that next week. In the interim, as I said, we have this conversation that will continue. You ask about what is next, what mental health counseling is available, what else is available out there. In the lobby right now, we have Lonnie Layton, who is a counselor, and he will be there to discuss options that are out there locally when it comes to mental health in a time where we need money, we need much more of that, on a local basis. So that will go on outside in our lobby. Thank you all so much for spending your time, for caring about this topic, and for being with us tonight and sharing. And thank you all for being here as well, and thank you at home. For now, I'm Liz Hurley, WAFF 48 News. Good night.